let's say you have a patient who has not had any treatment yet, and so they're theoretically close to plano. We had a question that just came in about contrast sensitivity. Did they ever complain to you about differences in contrast sensitivity between the two?
That's a great question. And I would say I've never had a patient be able to put that into words themselves. But no matter what, every time they're coming in, I'm refracting them and then showing. So we do like a couple baseline refractions before day one. So I can show them, hey, this isn't your final outcome. We have a lot of work to do here. And then I'll ask them if they actually notice that same phenomenon when both eyes are corrected for distance, and then just try to kind of point it out that way, that like, hey, when both eyes are seeing what they're supposed to be seeing, you can't really describe that same phenomenon to me, can you? And then they, more often than not, they can't. And then if they are like trying to, if they're remaining adamant about it, that it's a little bit different, is I just talk about how the plus is going to be there to read. And when you are going to be binocular with this, you're not comparing right to left, and you shouldn't really be able to constantly pick up the difference. If you are looking for it, you're probably going to find it. Um, but I would say the majority of people that are mix and matched are not complaining about contrast sensitivity difference. Maybe at the beginning they're very astute and really comparing right eye to left eye, which I have a whole conversation with them about. You can be as picky as you want in the first 20 days, but we haven't started to change some things yet. This is just so I know where to start when we get it going. So there are some people that are like a little bit more detail oriented than others, like all surgeries are, but I don't have patients as much before treatment one with those specific complaint types. And then if I do, I kind of do what I mentioned: refract, show them both eyes distance. What do you see now? More often than not, that complaint falls off. And also, more often than not, 6, 8 months down the road after lock in, they can't even bring it up to me again, because that's just something that they've adapted to.
Yeah, I really try to make it a point. I think you bring up a good thing. Even when it's LAL versus LAL plus, and then certainly when you do start to do the light treatments, you are making the eyes different, and they are working with a little bit of a different priority individually. So I tell my patients straight up, don't do this. We call this the refractive salute. When I walk in and they're doing that, don't do that. It's like asking me to throw a baseball with my left hand. It's going to look terrible. I'm a righty. But if if you ask me, do I notice that I have one hand better than the other at any given point throughout my day? No, it's only when I look at it to be isolated. So you're only doing yourself a disservice, I think, if you're looking for the difference. So don't. And because also neural adaptation is a very, very real thing. And it's different. It takes longer for different people. Some people get it right away. Boom, they are comfortable with the imbalance. Others, it takes time, and it can definitely take a while. So, Seamus, back to you. When you're considering doing an LAL or an LAL plus, I mean, is there certain lifestyles that really that mesh with this? And then between the two, between Eva and Seamus together, surgeon OD who's doing the adjustments, do you guys communicate during that process and decide how to do this, or is it once the surgery's done, Seamus, it's on to you, or how does that dynamic nature work?
I still think it's a team effort most of the time. She's pretty organized with the initial plan that was discussed at the initial consult before the lenses are implanted. So that's kind of my scaffolding that I will work on. And then most of the time, if I'm running into situations, I will bring her back into it on for most of the time, or I will at least inform her like, hey, I gave Jimothy a little click of minus in the left eye in the LA
Timothy, nice
plus,
guy.
and then I'm going to check it out here next week or so. And if I do some changes off of kind of the main plan, I don't bring them back 72 hours later. I give them like a full week to go out and try it that way. So it's not, I do have a little autonomy with it and the decisions that are made with it, but definitely on patients that are a little bit more type a little bit more particular with their outcome. Maybe they weren't super happy with like the last light treatment that they got. I will bring Dr. Kim back into it. And that is kind of like it does feel like a nice safety net for the patient. Sometimes they just need to hear it from the surgeon, and I'm totally fine with that. But I'd say I'm driving the car after she puts the lenses in. That's probably 80%, 90% happening without the surgeon's attention prior to the decision.
And this makes me realize that I think it's really important. It sounds like a no-brainer, but to on the EMR that we as the surgeons leave incredibly clear notes. If you're not the one who's doing the treatments, or if there are multiple people who are going to be involved in the pathway, the journey for the patient, the notes have got to be good. So my consult notes, I think they're okay, right, Seamus? I always talk about dominance. I talk about what they do. I talk about the plan. I really want Seamus or Dr. Boon Kong is our other OD who does a lot of my treatments to to have the benefit to understand what our goals are. And we see each other enough that if it's unclear, then they can absolutely ask me in person or text me and say, like, this one's a little confusing. Like, what is the goal? But it should be very clear. I think it's the surgeon's responsibility or whoever did the consultation to make it very clear what the goals are. Now that can change. We all get that. Sometimes patients think they're going to go distance in both eyes and they're convinced, but and then they actually want a little bit of micro or mini monovision, but and that's wonderful that they can. That's the whole point of it, right? But I think that we really need to make sure we're communicating with each other because this is such a team effort, you guys. Like it's actually a very beautiful thing if the team works together and the workflow is smooth. Patients are so happy that we're communicating to each other, that we're talking to each other for their benefit.
I think the team approach is, this technology highlights that. I mean, my clinic partner, Dr. John Vukic, him and I are in communication all the time. And it starts with a really good surgery. And it starts before that. It starts with really good biometry because you still want to be close. But the beautiful thing about this technology is you don't necessarily have to be perfectly close because you do have a little bit of a fudge factor.